Muchas gracias por todos por venir esta tarde. And that's the end of my Spanish. So, as a faculty member now, I have to give the full disclosure of my different roles and activities, and it's actually kind of interesting in and of itself because this is a brand new internet company, Cupid.me, which is creating apps and is launching a new way for people to communicate their STD test results. ISIS is one of the oldest internet-based and SMS-based companies to do sexual health services, and has worked in Peru, has worked all over the world. AIDS Project Los Angeles is one of the largest AIDS service organizations in Los Angeles, providing AIDS support and advocacy. And I'm going to talk a little bit about the WHO congenital syphilis illumination initiative. But to be successful and relevant in this field, and that'll be one of my conclusions, it's really important to be a good collaborator and to work with lots of different organizations, to seek a lot of different funding sources, because approaching sexual health is complicated and does take a variety of responses. So I was going to try to limit my talk today to these 4 infectious diseases: gonorrhea, chlamydia, syphilis, and HIV infection. And then I'm going to share with you some new things in terms of HIV infection that just came out yesterday. So this will be as up to date as possible. I always like to start with this image of urethral discharge that we saw at San Francisco City Clinic several years ago. As in this one image, it captures a lot of issues about human sexuality, but some also about the consequences of human sexuality, and people can get STDs, and that's a normal consequence of being sexually active. I'm going to jump right into what we've been doing with molecular-based nucleic acid amplification tests. As an infectious disease specialist, I'm particularly interested in the role of the laboratory and what the laboratory can do to support our efforts for prevention and control of infectious diseases. So early on, we had reported and identified that these nucleic acid amplification tests were much more sensitive, so they could more accurately detect infection in specific anatomic sites versus the conventional methods of culture. So in this one study, you can see that the LCR, which is a older type of nucleic acid amplification test, or PCR kind of assay, was about twice as sensitive as culture. That enabled us to go out to San Francisco, look at the positivity, and you can see about 1 out of 12 men who have sex with men in San Francisco carried gonorrhea in the throat. And this was the first kind of report of this high frequency of gonorrhea in the throat that made us think about transmission dynamics, about emergence of resistance, and the role of these throat infections in perpetuating the spread of gonorrhea. We also went on to demonstrate the improved sensitivity of the assay in rectal specimens, and you can see that compared to culture, the nucleic acid amplification tests are more than twice as sensitive. And then importantly, we're able to show that people could do self-collection. And as we think about moving our diagnostics and screenings from clinics to mobile vans, I was hearing this morning about the Via Libre's mobile van program. We want to potentially even shift that out further to put these diagnostics and screening tools in the hands of the people. And it's about empowerment of people to take charge of their sexual health. And when I get to HIV, I'll talk some more about innovations in that area. But one of the abilities of these molecular assays and people's capability to collect their own tests is there's now internet-based programs in the United States where people can go online, request their tests. The tests can be mailed to them. They can collect the specimens in the privacy of their own home, mail them back, and find out their test result, and then get treated on the basis of that test result. So the internet and demonstration that people can self-collect has been a great advantage to improvements in sexual health. And similarly, we're able to take the tools out into the community, and people collect their own specimens and do kind of widespread screening. This is one of the fairs in San Francisco where we did self-collection. And then from these kind of studies and outreach, you can see a variety of positivity, anywhere from 5 to about 11%. I think from our CPOS study here, the rectal gonorrhea positivity was about 4%, and for rectal chlamydia infection, which I'll cover also, is about 12%. And that may be because rectal gonorrhea can be more symptomatic, so people may seek screening a little bit earlier, whereas rectal chlamydia can just harbor as an asymptomatic infection. And then more recently, and this hasn't been something that's been utilized widespread in terms of public health programs yet, is that we're able to demonstrate that men could also collect a pharyngeal specimen themselves as well as a clinician could. So there was a concordance of over 95%. A high kappa value was translated into very good, and acceptability what was high. So this offers us another valid opportunity to enable people to screen themselves for pharyngeal infections. And we had done different projects where we put the screening tools out in the community and had people collect the tools from different venues and then collect their own specimens and send them in for testing. And this is something that could certainly be explored here as well. And then as a result of these experiments and these studies, both CDC and the WHO guideline is relatively new. It's the first for looking at STD treatment and prevention in MSM and transgender people, recognize the value of these molecular assays, of the specimen, of the innovations in specimen collection. And now increasingly we see around the world that that clinical sites, programs that are trying to address sexual health are including these types of assays. But really the big news and what's new in gonorrhea is the issue of antimicrobial resistance. So this shows across the United States the frequency of increased resistance of gonorrhea to the drug called Cefixime. So Cefixime is actually used here. It's available here in Peru. It's similar in terms of its spectrum to a drug called ceftriaxone. It's our last consistently effective drug against gonorrhea. And you can see, particularly in men who have sex with men, the frequency of resistance has gone from almost 0% to about 5%. Also gone up in California, less so in other parts of the United States or in other populations. But California and MSM have traditionally been kind of the canaries, or the first populations to demonstrate resistance to antibiotics. So this was published in the New England Journal of Medicine in February 2012. And Dr. Bolin, who was my former supervisor, is now the director of the CDC STD program. She decided it's time to sound the alarm. So now the alarm, the world alarm, has been sounded. And when the alarm is sounded, it's getting picked up by other media outlets such as Culture and Leisure section of Ynet News and Wired magazine. So it actually creates awareness in a variety of different venues, and WHO comes on board and says that this is a global health threat and the organism has become a super bug. And we had a meeting yesterday with the US Navy, and even the US Navy has recognized the threat of this super bug, and they told us they had orders from Washington to increase their surveillance and increase their capacity to address this organism. Now, we've been working with this organism and public health issues around it for 15, 20 years. We're excited finally to see NAMRU become interested in it as well. So now gonorrhea treatment has evolved from one drug to two drugs. And this is the first time in 75 years that now we have to start thinking about gonorrhea treatment like TB, where we have to treat with 4 drugs or 2 drugs in the consolidation phase, or like HIV, where we have to treat with at least 3 drugs. So now gonorrhea has become one of those germs that we need multi-drug therapy. And that's a huge change, at least in the United States, because we have to use an injection and we have to use a second drug. It makes treatment more complicated. It makes things that Jesse Clark does more complicated with partner therapies. We can't necessarily deliver an injection the same way as we can pills. And it's certainly a step backwards in terms of our ability to treat and control gonorrhea. And what the CDC does as part of its surveillance, it tracks from 1988 till 2011 the types of drugs that are used to treat gonorrhea. And you can see now it's predominantly ceftriaxone, which is this white and green. And it went from oral drugs by mouth to injectable drugs. And with that shift, we can monitor how drug use has changed. So the conventional response to drug resistance has been more newer drugs. So our infectious disease colleagues who lobby Congress and people who live around Washington and go, we need more drugs, we need newer drugs, we need special programs for pharmaceutical drug development. That's been the history of response to bacterial drug resistance, and generally it's been successful. So we've always been able to have new drugs, something newer, better, that will tackle the organism, but we're running out of options and we're running out of enthusiasm. More condom use, so the CDC says, well, if we could reduce gonorrhea by more condom use, we won't need, to worry about as much. Fewer partners, so traditional STD control responses, more condom use, fewer partners, more treatment adherence by doctors, use the right medicine, follow the guidelines, more vigilance for failure. So this is what the conventional response is. And then also more monitoring, so we need better surveillance. Now none of these in themselves have ever proven to reduce resistance, or even in combination have been proven to reduce resistance. So what we really need is actually more ideas. And this is a new idea that I've been developing. It's not necessarily innovative for infectious disease treatment, but it is for gonorrhea. Oh, there we go. All right. So when I looked at the distribution of resistance in gonorrhea, about 70% of the isolates in the United States are susceptible to everything. And, really many are susceptible to certain other drugs, and only about 10% are truly resistant to the fluoroquinolones. So the quinolones is these three essentially. So maybe about 10 to 15% are resistant to the quinolones, which is like a drug like Cipro. So Cipro is used here widely for treatment of gonorrhea. 10 to 15% is resistant to Cipro, but that means that 85% are susceptible to Cipro. So if we could use Cipro to treat based on susceptibility data, we might have a better shot at reducing the continued emergence of resistance. And this shows in San Francisco, we moved from about in 2000, we recognized this increase in resistance to Cipro. We stopped using Cipro, and then you can see the frequency of ciprofloxacin resistance came down tremendously. So it's somewhat surprising, our drug use in STD clinics may have had an impact on the ecology of the organism in the larger population. And this has actually been shown with other germs like streptococcus and erythromycin use in Finland. So based on some of those ideas, we have begun to develop a new molecular test where we could identify a gene change in the ciprofloxacin target to develop a molecular marker for resistance. Remember, much diagnosis now of things like gonorrhea and chlamydia are done by these molecular tests. So we don't have culture, we don't have organisms. So we need new molecular tests and new ways to think and measure resistance. So with my colleagues at the San Francisco Department of Public Health Laboratory, and with Mark Seidner, who was a UCSF medical student who came down here for actually a year, we developed a test that was able to differentiate between resistant and non-resistant ciprofloxacin susceptible gonorrhea. And then when we compared that test versus the conventional means of susceptibility testing, we can see that this PCR test was very good, and actually was 100% accurate at detecting susceptible infection and about 90% accurate at detecting resistance. So if the PCR test said susceptible, it was going to be susceptible. However, we never really rolled that out and moved that clinically, and I was thinking about this last year, and I said, well, why don't we use this clinically, and why don't we attach this to the usual mechanism and see if we can change the way we treat gonorrhea. So right now, there's a instrument made by a manufacturer called Cepheid, which we use for TB, which is used increasingly for TB diagnosis, which will tell you have TB, yes or no, and is it resistant, yes or no. They also have that for Staph aureus. It tells you if it's methicillin resistant, Staph aureus, yes or no. So the idea is, can we develop the same thing for gonorrhea, and then detect the organism, detect resistance, and then tell the provider or the clinician you have a resistant organism or not. We can reduce the use of these third-generation cephalosporins like cefixime or ceftriaxone, and then we can potentially decrease the emergence of resistance. So look for the outcomes of this study next year, and I'll let you know if it worked. So that's what's new from my perspective in gonorrhea. For chlamydia, similar story at some level for the molecular-based nucleic acid amplification tests. Again, the tests are much more sensitive than culture, and really culture was a no-go for public health. I mean, culture of chlamydia requires a tissue system, it requires correct collection and transport of the specimen, and we weren't making diagnoses of chlamydia with these culture methods. So the advent of amplification testing really opened the door for widespread chlamydia screening and treatment. We learned that much of rectal chlamydia in men is asymptomatic, so about 86% of people who have rectal chlamydia have it and don't know it, which also means they can spread it and not know it. And when we did our studies across the population in San Francisco, we found that about 1 out of 12 people carried rectal chlamydia. Here again in the CPOS study, it was about 1 out of 8, about 12% had rectal chlamydia infection. So these infections are common. People have them and they don't know it. They can spread them. And then importantly, we've been able to show that these rectal infections with gonorrhea and chlamydia increase the risk for HIV acquisition. So if someone has a rectal infection, that infection can change the environment in the rectum, can bring in different immune cells, and if someone's exposed to HIV, they're 5 or 6 times more likely to become HIV infected than if they did not have these co-infections. Part of our work has also looked at lymphogranuloma venereum, which is a type of chlamydia infection. So chlamydia trachomatis causes 3 kinds of diseases. It causes eye disease, trachoma, it causes genital disease, and it causes lymphogranuloma venereum, which is also a genital disease, but often more serious and associated with proctitis and lymphadenopathy. There were outbreaks in Europe associated with hepatitis C, and we didn't know what was going on in the United States. So again, based on the molecular characteristics of a outer membrane protein of the organism called PMP, you can see that the sequences are somewhat different, that these A through C, which causes eye disease or trachoma, is different than the D through Ks, which cause genital disease, is different than the L cervars, which cause lymphogranuloma venereum. So we could develop a PCR test to look specifically for L type, and then use that epidemiologically. And we found by going back to stored specimens that there was a steady rate, about 5% rectal chlamydia LGV type in San Francisco. And then we applied this to specimens we had in Peru from the CPOL study and found that none of those 86 positive chlamydia isolates were positive. So we could say it's kind of low-level endemic in San Francisco, but not epidemic and not changing in frequency. And we didn't see any in Peru. But this study actually looked mostly at urine isolates and not rectal isolates. We've never actually repeated it in rectal isolates. So that would be a study that we could certainly do, and we have the technology and we have the capacity to look for that in Peru, in rectal specimens. By looking at these rectal specimens, we're able to look at clinical findings and find out that people with L-type or LGV type were 7 times more likely to be symptomatic than non-symptomatic. However, much was still in asymptomatic people, and it has policy implications in terms of treatment. In California, we treat all rectal chlamydia, as you probably do here, similarly, with 1 gram of azithro or a week of doxy. The CDC, though, recommends 3 weeks if you think you have LGV type, but there's no diagnostic test for LGV that's readily available, so it's a little bit tricky to make that LGV diagnosis. And then very recently, and this was just submitted by Jean Cabeza 2 days ago, we embarked as part of her SAFR experience, a screening and treatment program in pregnant women in Lima. So right now, not in any country in Latin America, and not really in any low and middle income country, do they routinely screen women for chlamydia infection. Chlamydia infection in pregnancy has been shown by observational studies to be associated with miscarriage, fetal loss, preterm labor, low birth weight babies, pneumonia in infants, and conjunctivitis in infants. So serious outcomes. However, no one is screening. So we wanted to say, okay, well, what is the prevalence in women, pregnant women here in Lima, and is it feasible to screen them, to treat them, and will they do a self-collected vaginal swab? So that was another big question, because we're having pregnant women do self-collected vaginal swabs, and there's a concern, okay, is it going to be damaging to the baby? Is the provider not going to find it acceptable? There she is, Jean. I'm talking about your great work here. Thank you. So in a very short time, through tremendous effort that Jean did, she was able to enroll 603 women in almost a little under 3 months, really 2 months as the holidays, and found that 10% were chlamydia positive. And the UPCH lab here provided a tremendous asset to be able to do the test and turn them around in a reasonable time so we can use them clinically. We were able to treat 90% of women to date, and a very high proportion of partners treated. So this tells us that the prevalence is high, testing is acceptable, treatment is readily done, and we're preparing ourselves for a clinical trial to show that screening and treatment in pregnancy improves birth outcomes. And this potentially be the first clinical trial in the world to show that, and it could have major implications on maternal-child health throughout Latin America and other countries. Chlamydia screening is routine in Europe, in the United States, and in Australia, and it's actually not based on very good data. It's based on some observational studies that women with chlamydia had worse outcomes than women without chlamydia, but no one's ever done the formal trial to make the calculations of cost effectiveness, to make the calculations of number needed to screen and treat that are necessary for big policy in today's day and age. So I'm going to move from chlamydia now to one of my favorite infectious diseases, syphilis. And this is a dark field. So hopefully with our new syphilis project we will see some of these. And this is a lesion seen on visual inspection. So this is not anoscopically identified lesion. So this is a visual inspection of the anus, and you can see a characteristic syphilitic chancre. It's got a smooth kind of edge to it. It doesn't have a red kind of beefy base, kind of a non-inflammatory base. And the key thing is that these lesions are painless. So men or women who have these lesions don't know they have them, unless a partner identifies them or unless someone's doing a good clinical examination. Part of the syphilis story has been the issue of azithromycin resistance, and again using molecular methods. So the theme here is how to use molecular methods to improve public health. We were able to identify the resistance pattern and then report on the clinical and experimental outcomes of azithromycin treatment. So it was interesting that these resistant organisms had one single point mutation in the 23S ribosomal RNA, and that was sufficient to confer resistance. And that single point mutation made the organism resistant to azithromycin or erythromycin, and they were able to use this tool epidemiologically, and the tool is able to easily separate the wild type, which is the normal, sensitive, susceptible organism, versus the mutant, which is the organism that is resistant to azithromycin. And then this is just one example of a molecular epi study. We could actually characterize the trends from the introduction of the resistant isolate to the spread and increase of resistance over time. And then this actually became very interesting because around that same time in 2005, there was a very large trial in Tanzania which showed that azithromycin and penicillin G, a single dose of penicillin G for the treatment of early syphilis, was equally efficacious as azithromycin. So you can see that their follow-up cure rates were the same, irrespective of if they got treated with azithromycin and penicillin. And this was very exciting because this meant an oral drug could potentially be used to eliminate syphilis. However, because we're finding these resistant failures, we want to do a clinical trial and see if people with these resistant isolates were actually more likely to clinically fail, and we're able to show very early on that 2 out of 12 patients who got azithro failed versus 9 out of the penicillin G patients, treated patients, and the DSMB, the Data Safety Monitoring Board, stopped the study early, and that ultimately resulted in the CDC recommending against the use of azithromycin in syphilis as early as 2006 and repeated again in 2010. And azithromycin is not widely used unless you can prove that your isolates are susceptible and you don't have resistance. And this is something we like to do in Peru, and hopefully with our new syphilis study we're able to do that. So as I speak about our new syphilis study a little bit, this is going to look at how we translate technology such as the use of mobile phones for recruitment and retention, the use of the laboratory and molecular methods to monitor infection, the use of cytokines and new kind of immunologic measures to look at host response, to actually examine this triangle of infection. And this is kind of the classic infectious disease triangle when we think about how infections affect the population, how infections affect individuals. It's related to the pathogen. So different organisms can have different virulence, they have different characteristics in terms of their infectiousness, their duration of infection, how sick they make people. There's the environment, and in this setting we're thinking about people's sexual behavior, their venues, their sexual networks, their use of other substances, in particular alcohol, and the host in terms of the host's immune system. And those three factors come together, and that's what supports continued epidemics and the effect on the population. So that's one of the reasons I'm here this week, is to help launch this new 5-year study. So as I was saying about syphilis, I didn't want to neglect a short discussion on the global elimination of congenital syphilis. This has been going on since 1999, and now it's really picked up speed at WHO, and the Gates Foundation has finally demonstrated some commitment to the elimination effort, and targets have been set globally by 2015 to try to screen more than 90% of all antenatal care attendees for syphilis, and then of those who are positive, treat above 90%. The problem is most countries outside of PAHO has been very strong on this initiative, but outside of PAHO have not, do not have good monitoring indicators, so it's going to be a little bit of a challenge to know how far we go. And the burden of disease of congenital syphilis, Carlos and I were talking about this a little bit yesterday. Why Uruguay, which is a relatively small, fairly developed country, has a high burden of maternal syphilis. Honduras, but those are the two hotspots in Latin America. You can see there's a variety of countries in Central and Southern and Eastern Africa. China, while it has a modest prevalence of 0.4%, being over 1 billion people, is a significant population. Papua New Guinea has one of the highest prevalences along with Madagascar. So some of these are very large populous countries, Indonesia, China, that it's definitely going to be a challenge to achieve global elimination. The WHO's pillars of elimination are fairly typical, if you will, in terms of elimination efforts. It's around advocacy and financial and political commitment, increased quality of services, and this is probably somewhat good and enlightened way to think about it. If we can improve the whole and be more holistic about it, we can improve outcomes, and it's trying not to be a vertical program, but to have some vertical initiatives in terms of really focus on screening and treatment, and then have strong surveillance and monitoring and evaluation. And part of that, which we're going to be exploring here as well, is the use of this dual rapid test. So there's a new test which is on a single platform, which can actually detect both HIV and syphilis in the same specimen in the same test. And that's important because 1.4 million women have HIV delivered per year, but more women deliver who have syphilis in the world. And no one knows that. That there's more women in the world who are pregnant with syphilis than with HIV. Yet every day we think about PMTCT HIV, we don't think about PMTCT syphilis. And last June, I guess, 6 months ago, WHO twinned the PMTCT program, which means now it includes both HIV and syphilis. So when we talk about PMTCT, we have to think both HIV and syphilis, and as part of the evaluation of these rapid tests, we're going to be starting to do that here. So now I want to switch to HIV. It's obviously also an STD and also of high interest to everyone here in the audience, and just cover a couple of basic things and then some of the new information. So it's already been 10 years that we added HIV RNA screening, or looking for the actual virus or the antigen, to our routine antibody screening algorithm. So at the time we were using a second generation HIV test, which I'll get into a little bit more detail. But with a second generation test, you can detect long-standing infection but not recent infection. So we added RNA screening to that, and we got more than a 10% increase in our HIV case detection. So this was important for finding people who got recently infected, for finding people who were recently infected to get them into treatment or research programs, for finding people who are recently infected to help notify their partners and do the contact tracing to find new infections. We looked at the performance of different generation antibodies in 64 acute RNA specimens. And we found, increasing sensitivity by the increasing generation of the test. And that's why knowing the generation of the test you're using has epidemiologic importance. So if it's a second generation test, only 12% of these were positive. Third generation test, 42% were positive. And with a fourth generation test, almost 90% were positive. So a fourth generation test is actually pretty good. It's not perfect. And depending on the situation, you may want a perfect screening test or the best available. But finding 90% of these acutes would actually make progress in terms of finding people with recent infection. So now I'm going to shift a little bit because we've all heard about TLC, testing linkage to care, and kind of the new emphasis, not only in the United States but around the world, in case finding and treatment, or screening and treatment, or treatment as prevention. And just to show you two cascades, and we're calling these charts now the cascade. So this is an example of a cascade from Los Angeles, where it's estimated in Los Angeles County there's about 65,000 people who are HIV infected. That about 48,000, or 80% of those people, know they have HIV and they're diagnosed. And the past 3 days I've been asking everyone I've met with, what's the proportion of people who don't know they have HIV in Lima? What's the prevalence of unknown HIV infection? And the answer is we don't really know. So that's an important epidemiological measure that we need to know. We need to know how many people here have HIV and don't know it. In Los Angeles, about 20%. However, only about 60% of these people are in care. So a lot of people are diagnosed but not in care. Very high proportion are retained in care, but not 90%. Of those in care on ART, it's about 90%, but only 60% have a detectable viral load. So that translates to about a third of people who know they have HIV have an undetectable viral load in Los Angeles. And for prevention effectiveness at the population level, we don't know if this is sufficient or not, but I would probably say it's not sufficient to prevent ongoing transmission at the population level. Now, if we look at that in San Francisco, and it's a little different analysis, this looks at only people who were diagnosed in 2000 and 2010, so new diagnoses. So in these 2 years in San Francisco, 860 people were reported as a new diagnosis. 750 people, or 90%, were linked to care within 6 months. Substantial drop-off the number who were retained in care. Then about 80% were retained in care up to 12 months. If they were retained in care for 12 months, because San Francisco has a very aggressive treatment policy, almost all were virally suppressed. So a very strong association between retention in care and viral suppression, so that's a good thing. And that results in about 50% of newly diagnosed people are suppressed. So better than LA, if you just compare those two values. We have seen a decline in incidence in San Francisco the past 4 years in a row, so 50% may be reaching a sufficient level of suppression to reduce ongoing population level transmission. Also, it's important to remember that it's not just viral load, and some of the focus on community viral load I think is a little bit misleading as it's so narrow. We also have to remember that these people who are newly diagnosed reduce their sexual risk behavior. They modify the type of sexual activity they're having. They partner with different types of partners. They practice serosorting. They practice what we call seroadaptive behaviors. And we don't know necessarily how long those change of behaviors last, but there are data that show at least up to 6 months people do modify their behavior. So a combination, new diagnoses resulting in behavior change and viral suppression contributes to a reduction in HIV incidence. What's brand new is that the United States Preventative Services Task Force, which is a group of experts in prevention, just released, and this was reported yesterday in the New England Journal of Medicine, that the U.S. Preventive Services Task Force is recommending everyone at the age of 15 to 64 get tested for HIV. So that's a major policy shift away from risk-based testing. So we're talking today with the Safford students about risk and risk-based testing and measuring risk and everything. And that's been kind of the way forward for many years. But now we're saying everyone should get tested because it's cost-effective to find people and get them on treatment, and that treatment can act as prevention as well. These new recommendations do not speak to the frequency of testing, and that's a big hole, a big gap. But at least it's a first step to saying everyone who comes into contact clinically should be tested. It doesn't necessarily say where or how, but it says that everyone should be tested. And because the way the new healthcare law works in the United States is that a grade A recommendation, which this is from the United States Preventive Services Task Force, translates into a law that insurers must reimburse these costs, and they must be free, no cost to patients who are part of their insurance schemes. That includes public insurance and private insurance. It doesn't mandate that providers have to do this, but it mandates that this must be free and no cost. And then hopefully this will set the stage for increasing routine testing. And I think that's particularly important because as testing becomes more routine, it becomes destigmatized. And we know stigma is a significant barrier to testing. We know that fear is a significant barrier to testing. And as it becomes normal and routine, 20 years ago, cancer was very stigmatized and people didn't want to get screened for cancer. Now cancer screening, we're over-screening for cancer. So this is an important step that just was announced yesterday. Carlos mentioned some innovation. So this is probably the most innovative thing in HIV I'm doing right now, is that we put what we call a smart vending machine. So this vending machine is connected to the internet, and it's got a keypad, and we are providing users a PIN, a key, electronic key that they get online through a Facebook program. Then they go to this vending machine and they can self-vend a rapid self-HIV test. And right now it says this vending machine is for research subjects only. It will be available to staff and others in the future. Here's the instructions. Press the pound key, enter your ID, enter the number row, and you'll vend a test. Any questions, please call Dr. Young, who's my collaborator at UCLA. And the idea here is to, one, demonstrate to the community that it's okay to make tests kind of widely available. This is at the Gay and Lesbian Center in Los Angeles, which is one of the largest gay and lesbian programs, certainly in California and probably the United States. It also sends a message, that HIV testing should be easy and people can do it themselves. The results on this so far are actually quite modest. We've been giving these pins out to people on Facebook, but Facebook does not geo-target people. And Los Angeles is so big, people are getting pins who live 50 miles away, and this is not necessarily a convenient way for them. So we're updating this. We're moving the machine to the youth center. So there's a youth gay and lesbian center in LA, and we're setting up a SMS system, which actually may be live already, where people can SMS a pin request and then automatically get a pin delivered to them. And then they can use that pin right there and then to, that they've gotten through their cell phone, to access the test. And then the condition of receiving that pin is they agree to participate in a study and that as part of the study, they may be contacted by phone or SMS to tell us about their experiences in using the test. So the advent of the in-home test in the United States, the FDA clearance of this test has opened up new avenues for research. So as part of that public health model, these are some of my thoughts, that behavioral researchers should focus really on how to increase HIV testing at system provider individual level, lower personal barriers to testing and repeat testing, and Sky and I have been talking about that a bit, how to do that here. Increase motivations of persons to learn HIV test, understand why people don't want to learn their tests, understand why they do want to learn their test results. In terms of adherence research, I think HIV adherence research is a bit too narrow-minded, just focusing on HIV and not thinking about other chronic conditions where people have to take medications for a long time. And we could probably gain a lot of better understanding about adherence by working with other specialists. Advocates, particularly community-based organizations, should support public health efforts to monitor patients and engage in care and to support people in long-term care. And that we may have to rethink about our investments in primary individual level prevention that are just focused on individual level interventions without really thinking about the importance of structural interventions or things in terms of testing. However, retain the focus on vaccines and other biomedical interventions. So in summary, and what I shared with you today was that gonorrhea is becoming increasingly resistant if they're treated now with 2 drugs. There are potentially some cool ideas with molecular biology, how we can provide susceptibility tests to providers and they can treat with a variety of different drugs, which would decrease the selection pressure. Chlamydia is common, so it's actually more common in many populations than gonorrhea is. When we screen, we find it. In pregnant women particularly, we need to enhance our efforts to screen and treat and study that. Syphilis is an important issue, and particularly the integration of maternal child health programs for HIV prevention with syphilis. HIV, I shared with you that new testing protocol and how we're moving to increase more focus on case identification, finding that 20 to 30 to 40% of people have HIV and don't know it, and then supporting their increased access and adherence to treatment. So conclusions, STD and HIV science continue to evolve, which is good. It's a fairly rapidly changing and exciting field. The challenge for us, particularly now, us being academic funded researchers, is we have to think beyond the visible horizon. So we're thinking about programs and activities that we want to do in 5 to 10 years. So we have to, be cognizant of what's happening now, but think of things that are beyond what we can normally see. And increasingly, we have to work together, and we need to focus on a variety of different aspects of programs, and teamwork is critical. And that's actually something we've done, I think, very well here, is work as a multidisciplinary team with laboratorians, with sociologists, with epidemiologists to approach these issues in sexual health. A lot of the kind of more laboratory work was done by Mark Pandorian, San Francisco Department of Public Health, and Mark Seidner, who was a student here and is now an ID fellow at Harvard. So I want to thank you for your attention and answer any questions.